Hello friends, this is Sudarshan and in this episode we will talk about glaucoma. So there are three important types of glaucoma we'll talk about: primary open angle glaucoma, angle closure glaucoma and congenital glaucoma. So primary angle closure glaucoma first. As the name is primary, we don't know the cause. Angle closure, so mostly referring to the iridocorneal angle, and glaucoma being elevated intraocular pressure greater than 21 mm mercury. So the definition of glaucoma doesn't mean it is only elevation of intraocular pressure, it also optic nerve head changes and visual field loss. So coming to the etiology, as the name suggests, the cause is unknown. Most commonly it is seen in the middle-aged 50 to 60-year-old females, and the precipitating factors in this case are dim light, stress and use of mydriatic drugs. Coming to the stages and the features of every stage of glaucoma. So we have 5 stages: latent or suspect, subacute or intermittent, acute stage, chronic stage and absolute stage or stage of complications. So latent or suspect stage, this is an asymptomatic stage where patient has just come for a regular eye checkup. Only 2 changes are seen: shallow anterior chamber with narrow and occludable angles. Then subacute or intermittent stage. So there are attacks of glaucoma in intervals. So in this stage we have the symptoms of glaucoma coming up. Just mild symptoms like mild headache and colored halos will be seen. Acute is the emergency stage where within minutes to hours the glaucoma will be setting up. So in this case, apart from the regular features, shallow anterior chamber, narrow and occludable angles, we also have corneal edema and circumciliary congestion, along with nausea, vomiting, severe eye pain and rapidly progressive vision loss in one or both the eyes. Then chronic stage, where we have the most important 2 things: optic nerve head changes and visual field loss in open angle glaucoma, which we'll be discussing next. And also important is the Watts triad, VGT. So in Watts triad we have the glaucoma flecken, iris atrophy and dilated non-reactive pupil, that is nothing but mid-dilated pupil that forms the functional iris bombay. Because of functional iris bombay, iris atrophy will be seen. And in absolute stage we have the complications. So because of increased IOP, the eyeball will be stony hard, there will be corneal opacities and staphyloma or the bulging of the eyeball containing uveal tissue will be seen. So mostly an equatorial or ciliary staphyloma. And also in angle closure glaucoma we have the synechiae formed in the iridocorneal angle. So because of the synechiae in the iridocorneal angle, the aqueous outflow will be affected, and that is why the aqueous humor will flow backwards and hit the lens. That is, glaucoma can be a reason for traumatic cataract as well. And when it comes to the diagnosis, we will go for gonioscopy, fundoscopic examination to see optic nerve head changes and visual field loss, and IOP measurement by digital tonometry, perimetry. Also we can go for optical coherence tomography or OCT. So treatment, medical management, various glaucoma drugs like myotics like pilocarpine, beta blockers like timolol, alpha-2 agonists like dipivefrin and aplonidine, prostaglandin analogs, most commonly latanoprost, and apart from that carbonic anhydrase inhibitors like acetazolamide or dorzolamide, or we can use the mannitol as well. And also we can do trabeculectomy and trabeculotomy, that is take space in the trabecular meshwork and increase the uveoscleral outflow to drain the aqueous humor. Also we can do laser or peripheral iridotomy using Nd:YAG laser to make a space in the iris for alternate pathway to drain the aqueous humor. And the diagnosis and treatment, mind you, will be the same for all the forms of glaucoma, which we will be discussing. So that is about angle closure glaucoma. So coming on to primary open angle glaucoma. So here the cause is unknown, but it is thought to be the comorbidities like diabetes, hypertension, smoking, thyroid, and apart from that ischemic CRVO. So these are some important probable causes. And the pathogenesis, there are two mechanisms here. One is the formation of the crystalline network in the trabecular meshwork, or it may be because of the retinal ganglion cell death by apoptosis rather than necrosis, causing calcium influx and nitric oxide release. So the clinical features, symptoms will be same for any kind of glaucoma: painless and progressive vision loss, mild headache, eye pain, and delayed dark adaptation. Then coming to the signs here, these signs will be seen in the angle closure glaucoma in the chronic stage as well. So optic nerve head changes in this. So we have cup by disc ratio asymmetry, which is greater than 0.5. Also we'll have optic disc atrophy, blurring, hyperemia, edema, optic disc elevation. Apart from the thinning of the neuroretinal rim, disc pallor, hemorrhages, and now the most important bayoneting sign is the double angulation or blood vessel kinking at the optic cup margins, laminar dot signs where we see fine slit-like openings in the lamina cribrosa, and then peripapillary atrophy where we see the patens lines due to the retinochoroidal tear, which we see in the pallidema as well. And the visual field loss, we have the arcuate or Jerem scotoma, where we can see an arc-like structure which starts from the blind spot extending to the nasal horizontal meridian. So basically it fans out from the blind spot. And when two arcuate scotomas come together, that is your Seidel scotoma or double arcuate scotoma, which looks sickle shape. And Roney's nasal step is a horizontal line that is drawn from the nasal horizontal meridian. And the common thing between Roney's nasal step and isopter contraction is the asymmetric nerve fiber bundle loss, which we see. Right. So these are the visual field defects, and this is all about the open angle glaucoma. And lastly, coming to congenital glaucoma. So this is common in children. So there are three types are there: true, infantile, juvenile. So true will be the ocular enlargement, infantile will be the boophthalamus or the bullseye, and juvenile very common in 3 to 15 years age group. So we can say mostly in the third birthday of the child we are going to see congenital glaucoma. So the main pathology here is the trabeculodysgenesis. That means the trabecular meshwork is not formed properly. So that means the aqueous humor will not drain properly because the iridocorneal angle is affected, and when the aqueous humor puts pressure on the iridocorneal angle, iris insertion will also be affected. So coming to clinical features, the symptoms in the case of a child: eye watering, photophobia, blepharospasm, corneal opacity, and axial myopia. So antero-posterior axial length of the lens will increase. So something like a pathological myopia we will see here. Most important sign here is corneal edema, and apart from that Habs striae, where tears in the decimates membrane will happen because of constant rubbing of eyes in the child, and then deep anterior chamber with the disc cupping. Right. So this is all about the glaucoma. So thank you so much. We will see in the next lesson.